Assalamu alaikum, sir.
Hello,
Assalamu
Professor.
alaikum.
Hello, Professor Raza.
Hello, Riyaz.
Hmm.
Dr. Victor Hugo, how about you? And Dr. Ahmed, hope you be good. And our Dr. Um, uh, क्या नाम है यार अपना
Amir Salir.
Amir.
Nice to
Amir, how
meet
about
you,
you?
sir. I'm
Thank
okay,
you so
sir.
much. Thank you so much. So, where is
So,
the presenter?
Assalamu alaikum,
presenter
sir.
here, sir.
Wa alaikum salam. Dr. Mahjabeen, how are you?
Alhamdulillah, sir. How are you?
I'm good. So, are you ready?
Yes, sir. Yes, sir.
So the Department of Neurosurgery, Liaquat University of Medical Health Sciences, which is located 150 kilometers away from the Karachi. So this is a very center place for the rural and the urban area of the Sindh province of the Pakistan. So Dr. Mahjabeen is now the consultant neurosurgeon. She was trained under me in Liaquat University Hospital, and she was let you know about that, her previous achievements, that she has been taking the positions during her undergraduate training. She was the position holder in her professionals, MBBS. And after that, she came into the neurosurgery, and she was interested to be a neurosurgeon, though she is the single child of the family, and this was a very hard for her to take this decision, because the neurosurgery take the more time to detach with the family. So I think this was the very brave attitude of this brave lady. She was very little. She was just a kid at that time when she was an undergrad, and she came to me just like my child, and she then be trained. And I know that she had faced a lot of the problems of the family, and but again, finally she got a lady neurosurgeon, got a position in the history of the neurosurgery in Pakistan. So wonderful. And even there are a lot of the lady neurosurgeons are coming all over the Pakistan in many different departments, and they are very doing very good in the neurosurgery. So it means the neurosurgery or any field doesn't declare that it is only for the male dominants, but the females can also present and do as much as the males in the every field of the life. So thank you so much, Mahjabeen. You are taking this task for the this presentation, and I am also thankful to the Amir Sagir. I told him that she will be the moderator, and now I give the speak is the is a mic to Dr. Amir Sagir to be a moderator of this session. Thank you so much.
Thank you, sir. Professor Riaz is like an elder brother for me, and whenever I want something or I want to ask something, he always there to help me. It's a great honor for me to attend this meeting as a moderator. I like Mahjabeen to start the session, please.
Thank you so much, Sir Riaz and Dr. Amir Sagi. Obviously, having mentors like Sir Riaz has been a blessing always. And just because as a female neurosurgeon, I am standing here and giving this presentation on this platform, it is because of the blessings and the mentorship of the Professor Riaz. Thank you so much, sir. Thank you. It's all because of you. So we'll start with the presentation today, and I'm very pleased to be presenting this topic, though it is a very basic topic, and it is primarily intended for the undergraduates and the junior postgraduates. So I have tried to keep it very basic and simple so that it is understandable to the even junior most colleagues. So, if since few sessions that we have attended from the spinal cord module, we know that spinal cord is roughly around 45 in males and 42 in adult female patients and female population. It tapers. The topic of today's presentation is to study about the conus, that is the lower spinal cord, which consists of three parts: the conus, cauda equina, and the filum terminale. So if we see, we have already seen that the cervical spinal canal, cervical spine has 8 segments, then 12 segments in thoracic, 5 in lumbar, and then sacrococcygeal. There are 2 enlargements. One is the cervical enlargement, and other is the lumbosacral enlargement. And today we will be focusing on this area, that is the lumbosacral and the area of conus, and we'll dive into the details of its anatomy. If as far as the coverings are concerned, the same 3 coverings which are covering the brain are present in the spinal canal as well. But the importance here is that the pia has special attachments, just as we saw in above sections of the spinal cord, the denticulate ligament. The lower section of the spinal cord has another special extension of pia, which is the filum. So we'll be seeing that shortly as well. So the key components of the lower spinal cord, as we discussed, are conus, cauda, and filum. So we'll go to all of them one by one. So in this picture, this is a cadaveric dissection showing this horsetail appearance, that is the cauda equina, the tapering end of the cord, which is the conus, and the pial extension, which attaches the conus to the coccyx, which is the filum terminale. So starting with the conus is a bulbar cone-shaped terminal part of the spinal cord, which is found at the level of L1, L2. Above it is continuous with the epiconus that contains the lumbar segments, and then it itself consists of the sacral segments. Now, this is a very important concept, that the conus itself consists of these segments, the S2 to S5. And the coccygeal segments as well. It then tapers below to form the filum terminale. The diameter of the conus in anterior-posterior dimension is 5 to 8 mm, and the transverse diameter is 8 to 11 mm. Then we have a very important clinical correlation here, that sometimes there is a small ventricle that is called as the fifth ventricle or the terminal ventricle that can be present in the conus medullaris. And it's a normal variant, and clinically it is not such significant, but sometimes it can be confused with syrinx. So we should keep this anatomical landmark or anatomical variant in mind as well when we are discussing or when we are seeing the MRI scans as well. So that can be mistaken. Also, we know that conus can be involved in a lot of pathologies. We'll see them as well, especially the tethered cord syndrome and conus tumors, especially the myxopapillary ependymoma, that we'll see in the next slides. Then we have the filum terminale, which is the anchor that attaches the conus to the coccyx. Basically, it is nothing but it is an extension of the pia, and it is around 22 centimeter in length, and it has 2 parts. Then the part which is inside the dura is known as filum terminale internum, and the part which is outside the dura is filum terminale externum. So this is a picture. We can see that this strand of pia is the filum terminale. It attaches the conus to the level of the coccyx. Now it is further divided into 2 parts. Above the level of S2, the part of the filum that lies within the dural sac, that is within the thecal sac, is known as the filum terminale internum, and the one that goes outside the dural sac or the thecal sac and goes all the way to the level of coccyx is known as the filum terminale externum. Again, this picture, we can see that this is the filum terminale internum here, and then it pierces the dura, goes out, and then attaches to the coccyx, which is called as filum terminale externum. Now, this is an intraoperative image of filum terminale, and we all know that how to differentiate filum terminale clinically, as in by seeing it grossly from the nerve roots of cauda equina, and also obviously the definitive method is by intraoperative neuromonitoring. Then we go to the cauda equina. The cauda equina actually is nothing but a horse tail that consists of all the lower lumbosacral roots from the lumbar L2 to the sacrococcygeal area, and that descends into the subarachnoid space in the thecal sac. And this shape of the rootlets is is in the form of a horse tail, so that's why that's known as the Cauda equina. The literal meaning of Cauda equina is horse tail. So if we go understand this thing, then it is very important to understand that there is something called vertebrosegmental disconcordance. Now, what is this? Basically, there is differential growth of the spine and the spinal cord. So that's why the spinal cord segments, they do not align with the spine segments. So that's why there is a difference in the, if we talk about the spinal level and the cord level, there is a difference of the segments. So how then we calculate? Obviously, we know that during embryogenesis, the growth of the spine is faster than that of the spinal cord. So that's why the spinal cord ends in a newborn at L3 and then further in an adult at L1. So that's why we have to calculate the level of the spine by adding a few levels as we progress from the cervical to the lumbosacral. So it was beautifully discussed by Sir Victor as well in the previous lectures. So I'll just be repeating it, that in the upper cervical level, we have the same cord. In lower cervical, we have to add 1. In upper thoracic, adding 2. Lower thoracic, we have to add 3. And then we know that at the level of the conus, which is at the level of the L1, we have the lumbosacral segments, L2 to sacrococcygeal segments. So this is very important to understand in order to localize the level of neurology and to understand the segment of the spine which is involved in a certain pathology. So that's again a beautiful chart which is showing the segments of the spine and the vertebral body segments that correlates with each specific thing. So understanding this Cauda equina also leads us to the basic understanding of the concept of traversing and exiting route. So we know that because of the arrangement of the spinal nerves in the form of a Cauda equina, the nerves have to leave at a particular intervertebral space of that corresponding vertebrae, right? So, but at that level, we have those routes as well, which are going downward in the form of a Cauda equina, in the form of a horse tail, to reach at their respective level to leave from their respective foramen. So this gives rise to the concept of exiting nerve route and the traversing nerve route. So this concept becomes very important. Obviously, it's a very fundamental concept, but it's a very, very important concept to understand the nature of the root compression in disc prolapse. So we all know that the traversing nerve route, for example, this is the traversing nerve route. This, for example, on this side, we can see this is the L4 traversing nerve route. And in the disc prolapse of L3 to L4 intervertebral space, there will be compression of this traversing nerve route. So exiting nerve route is compressed whenever the disc is somehow laterally. So this concept is also important when we are discussing the Cauda equina. Then let's go and see the cross section and the different sections of the Cauda and conus. So this is a mid-sagittal view, and this is the coronal view. Obviously, here we have centrally placed central canal. Then we have outer gray matter, and then this is the white matter. This is the tapering end, which is of the conus, and these are the fibers which are forming the Cauda equina. Cross-sectional anatomy has been profusely discussed in the previous few lectures, especially in the cervicothoracic anatomy. We have a lot of ascending and descending tracts, so I won't be repeating that. We have already discussed. The important thing which we have to see is how to compare the cross-section of conus and upper spinal levels. Now, if we see in the lumbar segment, we do not have obviously fasciculus cuneatus, right? So in lumbar and sacral segments at the level of the conus, we won't be having the fasciculus cuneatus, number 1. Number 2, if we see the anterior gray column, it is comprised medially for the group of cells for lower limb muscles, and then centrally for the group of cells of lumbosacral nerve. Again, here medially, we have the group of innervation for trunk muscles, and then laterally we have group of innervation for the lower limb muscles. That's about the anterior horn. Then we see if the posterior horn, we have the substantia gelatinosa, nucleus proprius, and nucleus dorsalis. And the white matter, obviously, we said that the fasciculus cuneatus will not be present, but fasciculus gracilis will be present, and the lateral, the corticospinal tract will be as it is, which is present in the lateral white matter. Another thing is that for the sacral cross section, again we have the same things, but obviously here will very small amount of fasciculus gracilis will be present. Fasciculus cuneatus obviously will be not present, and the lateral gray column obviously will not be present in the sacrum as well as even in the lumbar, but just the upper lumbar segments. Here in this picture, we do not have upper lumbar segment. This is the L3 segment, but if for say this is a segment of L1 or L2, we'll have a lateral gray horn or the intermediate horn for the thoracolumbar outflow as well. Here, as we can see in the 6th thoracic vertebrae cross section, we have this lateral horn. So this is how there are a few differences between these things. So again, we can see the cervical, thoracic, and the dorsal, how the cross-sectional anatomy differs at these different levels. So this is how we should keep in mind that obviously in the cervical spine, we'll be having both the cuneatus and gracile. And then when we come to the lumbosacral, we'll be having only the gracile dorsal column. Again, this is an axial view, which is showing the typical anatomy, which is obviously the basic for every cut, but the few differences which I already showed. And this is again a zoom in view showing the substantia gelatinosa, nucleus proprius, and nucleus dorsalis in the dorsal gray horn, and in the ventral gray horn, medially placed trunk musculature motor neurons and a bit laterally placed motor neurons for the lower limb muscles. This is an axial view, which is showing the conus region on the scan, and this is a cadaveric dissection again, which is showing the conus region, and this is the heart-shaped gray matter, and this is the white matter. This is the anterior median fissure, and here it's very subtle, but the posterior median sulcus can be seen as well. Now, when we talk about the conus and cauda, we obviously have to see the dermatomes and myotomes of the lower limbs as well. Now, that is important because the lumbosacral prominence occurs at the level of the conus. So from there, we have different nerve roots which arise and form the lumbosacral plexus. So in order to understand the nerve roots, we should know that when the roots are left from the region of the conus, they take a dural sleeve with them. And then the dural sleeve then follows them up to the intervertebral foramen, and then the nerve root then goes outside into the in the extravertebral space. Again, these are the anterior rootlets, and see how they are piercing the dural sac, and they then carry a sleeve of dura with them as they pass out. Now we have to understand the difference between cauda and conus in terms of their segmental, the segments that are involved in conus and cauda. First of all, we should know that in conus medullaris, the basic, or you can say I already told in the previous slide that there is a part which is called epiconus, and then there is a part which is known as conus. The conus contains sacrococcygeal segments of the spinal cord, right? And the epiconus contains the lumbar. Okay, we can see the lumbar 1, 2, 3, 4 arising from this red-shaped structure. This is the epiconus. Number one, this is concept number one. The concept number two is that the cauda equina obviously comprise of all these nerves, that is from L2 to coccyx. So this concept is important in understanding the difference between the cauda equina syndrome and the conus medullaris syndrome. So we can see that in conus medullaris syndrome, we have involvement of S1 to S5 and coccygeal nerve root, whereas in cauda equina, we can have involvement of any nerves starting from L2 to coccyx. This is the reason that we know that why there is differential involvement of knee jerk and ankle jerk in conus and cauda, because the root value of knee jerk is L3 and L4, obviously we know, and the ankle jerk root value is S1, S2. So this is how there is differential involvement. For example, ankle jerk can be involved in, as it is involving S1 and S2. So it can be involved in both of the syndromes, whereas knee jerk can be involved in Cauda only. So this is how we differentiate Cauda and Conus. Another difference can be made on the basis of bulbocavernous reflex. We know that the afferent and efferent pathways both are by the pudendal nerve, and the bulbocavernous reflex is can be affected in both of them, but it tends to come back after a period of spinal shock in conus medullaris syndrome. So in conus, there can be a reversal of the bulbocavernous reflex, but in Cauda equina, sometimes it doesn't come back. So this is how, again, I just, whatever I said, we'll now see in the chart. The conus medullaris syndrome, it occurs at the level of L1, L2 vertebrae, and the spinal level, again, this concept is coming of vertebrosegmental disconcordance. So vertebral level is different and spinal level is different. For conus, the spinal level is sacrococcygeal, and Cauda equina, the spinal level is lumbosacrococcygeal. So conus medullaris is basically a CNS type lesion and causes sudden and symmetrical symptoms, whereas in Cauda equina, we have gradual and asymmetrical symptoms. In conus medullaris, the ankle reflex is affected, but the knee reflex is not affected because the root value of knee reflex is L3 and L4, which is not present in the conus region. So that's why the knee reflex is not affected. But in Cauda equina, as we know that we have lumbosacrococcygeal roots, they all can be affected. So that's why we can have knee reflex affected and we can have both ankle reflex affected as well. And we saw that the bulbocavernous reflex was being supplied by the pudendal nerve, the pathway was mediated by the pudendal nerve. So the conus medullaris really doesn't have much of it. Even if it is involved, then it's purely due to spinal shock, and that recovers once the patient comes out of the shock, but it is lost in the Cauda equina syndrome. The motor, again, it is less marked because in the conus, we have just sacrococcygeal nerves, and that's why the lumbar nerves are spared. That's why the lower limb muscles are less markedly involved, right? There's just distal paresis of lower limb. But in Cauda equina, we have lumbosacrococcygeal nerves, so there is more marked involvement of the lower limb muscles, and even atrophy and flaccid paralysis can be seen. Sphincters can be involved in both of them, because sacrococcygeal has S2, 3, 4 have to do with the bladder thing. So that's how sphincter can be involved in both. The sensory, obviously, numbness is more localized in the perianal region because of sacrococcygeal, but that typical saddle anesthesia is seen in Cauda equina, because there is involvement of the not just the sacrococcygeal part, but also the medial thigh is affected, the area of the saddle is affected. So that's why it is more extensive sort of numbness. Now, if we see a few pathologies of conus and cauda, this is a very beautiful picture showing a low-lying cord with tethering, right? So this is basically a tethered cord syndrome. Normally the cord ends at L1, but this is showing a low-lying cord and low-lying conus with tethering. Again, this is a low-lying cord, and this Cauda equina roots can be seen, and there is tethering of the cord. This is an intraoperative image which shows this is beautiful filum, and that filum actually is tethered, and it has caused low-lying conus. Again, another beautiful case taken from Radiopedia, and this shows again a low-lying conus and this lipoma which is present in the filum terminale. So this is a tethered cord with filum lipoma. Another case of tethered cord, but now with the split cord malformation, we can see these two cords within the same sac. This is an intraoperative image of the split cord malformation. Again, a case of tethered cord, again with the split cord malformation. We have the low-lying conus, and we have on axial sections, we have the two. So we all know about the split cord malformation, type 1 and type 2. So this is how it goes. And the few other pathologies of the conus. Number one, obviously we know the myxopapillary ependymoma. The myxopapillary ependymoma has it arises from the conus and the filum region, and this is how it is attached to the filum. So it's very important to intraoperatively distinguish filum from the surrounding roots of the Cauda equina. Obviously, clinically, we can differentiate, but the most important is intraoperative neuromonitoring. It's another case of Cauda equina schwannoma. Okay, so we see that this is the root which is basically involved. This is the engorged vessel on the root, and then this is the schwannoma which is arising in the distribution in the length of the root. Then another case of conus, which is now conus cavernoma. So this is an intraconal cavernoma, and this is an intraoperative picture. This is the case of cavernoma. Another case of conus and Cauda AVM. Again, here we can see there are different veins and the dilated arteriovenous malformation at the conus region. A few words about the monitoring. Obviously, the monitoring of the lower limbs, the SSCPs and MEPs, they are carried out in cases of all the tumors of the conus and also the neural tube deformities like meningomyelocele if we are going to carry out. So we should know that in upper extremities, obviously it is done by radial and median nerve, but in lower extremities, we do it by peroneal and posterior tibial nerves, mostly posterior tibial nerve. So this is how the SSCP is recorded. The different leads which are connected to the peripheral nerves, then the recordings are taken place from different sites. For example, N8 from the popliteal fossa, and then N22 from the DRES, then P31 from the cervicomedullary junction, and then it goes up. So obviously any drop in amplitude or any hindrance in the pathway of the SSCP will be indicative of some kind of intraoperative damage or injury to the pathway. So basically intraoperative somatosensory evoked potentials are to assess the dorsal columns. Then we have MEPs as well. The MEPs are obviously assessed at different myotomes and different muscle groups. In lower limbs, we can have the lower limb MEPs can be obtained from any of these muscles. Another important concept is of the D wave. D wave is direct measurement of the nerve stimulation at the level of the epidural catheter. So this is also very important, and in a way that it is not affected by the anesthesia, and we can directly measure the impulses from the epidural space. So this was just a basic review from my side, and obviously I am very, very thankful to our seniors for giving me this opportunity to present a few words from my side, and I'm very happy to answer any questions if they are. Thank you.
Okay. Thank you, Dr. Mahjabeen. It was an excellent presentation done by Dr. Mahjabeen. Okay, any questions, please? I'd like to Dr. Professor Victor to add some of his experience in this presentation.
Thank you so much, dear professors. So first of all, I want to congratulate to Doctor. Really nice lecture. Surgical pictures are really good and many variants about pathology over there. So I have operated lipoma in the conus medullaris, and for me is sometimes really difficult because lipoma is very attached to pia mater, and if when you are resecting this kind of pathology, you need to protect the vessels, and they are very, very small. So for me is really an easy, but at the same time difficult resection of this kind of benign pathologies. So thank you so much, and again, congratulations.
Thank you so much, sir. Thank you. It is an honor to be present among legends like you. Thank you so much, sir. Thank you.
Okay. Anyone like to add something or want to ask something from Dr. Mahjabeen? Ahmed, you like to add something or share your views? Dr. Ahmed?
Yes, as Dr. Victor said, congratulations, Dr. Mahjabeen, for this very nice presentation. It was have a lot of good informations for junior neurosurgeons and for residents, and it was delivered very easily and very understandable to all junior neurosurgeons and residents. So thank you for this very great presentation.
Okay, nice.
Thank you.
Okay,
Thank
I like to conclude the meeting to summarize Mahjabeen's presentation. Okay, basically we have MRI nowadays. Okay, but still we are clinicians and we should have to know what is Cauda equina syndrome, what is Conus medullaris syndrome, and how the patient present with these syndromes. Okay, ultimately at the end of the day we go for MRI, no, but at least we should have some idea at what place we should do this MRI and what we are suspecting. Okay. The patient came with these weakness and sensory deficits in lower limb and has more back pain than what syndrome we are expecting as compared to the leg pain. Your residents are not very active, Ahmed.
Yes, that's correct.
It's okay. No issues. Okay. With back pain more and we have less leg pain. We are more involving the Cauda. Sorry, we are more in the Conus region. The region is more in the Conus region. And we know degenerative issues like degenerative disc are more common with these issues as compared to the other things like tumors, like metastatic tumors, and other causes like injuries. Okay, although these all things are very rare. Okay, and Cauda equina syndrome, as we know, is called as surgical or medical emergencies. Okay, but we have to see whether it is an emergency or not. Sometimes the patient presented you after a week. Okay, and he's not stable cardiac wise, or is old, or have multiple comorbids. We have to address these comorbids first. It is already a week late. Okay? If we spend 1 or 2 days in adjusting his comorbid, providing his legs are stable, then it's okay. Okay, it's not like that we have to operate this unstable patient at the middle of the night. Okay, it's a small thing. Yes, if it is a young patient and losing his things quite, then we can do the surgery next morning. Even then, I don't prefer to do these kind of spinal surgeries at the middle of the night. Okay, so these are some points from my side. Okay, nice to
Professor
meet you.
Riaz.
Nice.
Okay. If you
Is
have
Professor Riaz here?
yes, I see him. If you have any remarks or comments. And also I see a question here in the question sections. If you can see, Professor. We have a question from Dr. Ahmed Al-Ghanimi.
What are the features that Cauda equina syndrome has rather than other LMNL, lower motor neuron lesions? What are the features that Cauda equina syndrome has rather than other lower motor neuron lesions? Mahjabeen, can you answer? Features of Cauda equina syndrome, we want to ask. And how can you differentiate it from other lower motor neuron lesions?
Yes, sir. So the low motor neuron lesions obviously will be having other features as well. But in Cauda equina, there will be asymmetrical distribution, and not just one root will be involved. There are more likely few roots will be involved in the Cauda equina. So a single lower motor neuron type of lesion or a root injury, for example, will be having one root involvement. But Cauda equina will be having multiple roots involvement. Also, another thing that the bladder wobble symptoms, they are usually not seen with single root involvement. or other lower motor neuron type of lesions. But in Cauda equina, this sphincter involvement is more common. Another differentiation is the saddle anesthesia. The saddle anesthesia is seen in Cauda equina, but other lower motor neuron lesions typically do not cause saddle anesthesia. So these are one of the few differences that can differentiate Cauda equina from other lower motor neuron lesions. Hopefully that answers the question.
Well said by Mahjabeen. You correctly answered the question. So, Professor Riaz, sir, we need some comments
I will
from your
not say
side.
the well said because I have listened her since
Okay,
decades,
okay.
more than one decade. And I
She's very
really
good.
always appreciate and enjoy when she talk, when she present. We worked very hard and on the presentation. So it was a wonderful presentation from the every point of view that she has presented about the Cauda equina very well.
Thank you, sir.
Agreed.
Good job, Mahjabeen.
Thank you so much, sir. Thank you.
Now we'd like to conclude the session. Anyone want to say anything, any comments or any question answers? Yeah, Ahmed, thank you for inviting all of us. Thank you, Mahjabeen, for an excellent presentation. Thank you, Professor Victor, for your time, and Professor Riaz for your time. Thank you, everyone.